to support. So we're going to need to support those foster parents. And that's done primarily with a trained program supervisor who's going to coordinate those efforts and try and direct the kids towards the most appropriate behavior. We've done several clinical trials of treatment foster care with a variety of different groups. And again, just like that LIFT study, it seems that the effect is not on decreasing. We haven't completely eliminated delinquent behavior. In fact, the number of kids, there's more kids that have 0 referrals, but the kids who leave treatment foster care and end up having another referral remains roughly the same. The impact of the intervention is on kids who have multiple subsequent referrals. Kids who had 2 or more referrals drops by what is that, 75, 80%, from 25 to 5%. That's where the impact of the intervention is. This has been difficult for a lot of folks, and it suggests a difficult interface. We are implementing this program right now in Manhattan and having an incredibly hard time because one of the difficulties of moving forward with a program is the program like this is interfacing with the parole officers. We know that kids are not less likely to commit, at least might still commit one more offense. And yet if what we're going to do is suffer a revocation, we're going right back into the same procedure. If what we can do is look at whether or not this kid is going to commit multiple offenses, what's the nature of the offense, what's the seriousness of the offense, we can work closer. And just as an example, a lot of the kids are on, when they leave a facility and come into treatment foster care, on very tight probation orders. And we've been able to work this out in Lane County for a long time, but it's when we go into a new area, it's a new negotiation. A lot of those kids are on really tight probation orders, meaning that if they leave and are AWOL from the program for 24 hours, they get revoked and they get sentenced back. That's a difficult thing within treatment foster care where the kid has a new opportunity to do that. And we need to look closely at, is this really a community safety risk, or is this something that we can work with within the program with enhanced supervision and support? In terms of reentry specifically, services need to be individualized, and this is the conundrum. What I've told you is that each one of these kids comes in with a different constellation of risk factors, a different constellation of protective factors in their environment. These things are unique for each kid, unique for each family. And yet at the same time, we know what the proven treatments are. And so the question becomes, when do we individualize those programs? When do we start to look at how this program is going to affect this individual kid? We know that the effective programs are going to include the family and be multiply determined. And I think when those things are going to need to be individualized is when we know there's a differential risk. Kids coming out of a facility are no different necessarily from kids that are just out in the community, unless there's some distinction clear and inherent in who that child is. At the same time, there are things about kids that we know are distinct and clearly different. For instance, girls are clearly distinct from boys in terms of their offending patterns. For the longest time, when people would do a gender-specific treatment for adolescent girls, basically that consisted of putting a pink cover on the treatment manual and putting it out again and saying that that was the girls' program. We know that that's not effective, and we know that girls are fundamentally different in that the boys that we need to be most worried about are the boys who start very early, early starters, kids who are involved and are known to the police and are known to the community very early on, and then continue to progress up in terms of their offending history from that point forward. Those are the kids who later on in life are most likely to penetrate the adult system and are likely to have those long-term problems. Many of the girls who have long-term problems with delinquent behavior are unknown to authorities through elementary school, and that we see an upsurge in female offending happening in middle school and early in high school, when the girls start to be exposed to older male peers, when there's more drugs and alcohol in the environment. We know that these girls have a different offending pattern. And so those treatments need to be looked at very closely with girls. And we just finished a second randomized control trial with girls. And again, the data is really interesting in that we're going to affect some of those behaviors and not others. For the girls, the substance abuse responded to a very targeted intervention. When we just did our regular treatment foster care, the girls' rates of substance abuse did not go down, while the rates of offending did. On the other hand, pregnancy outcomes, so 25% of the girls come to us with a prior pregnancy, and a huge number of delinquent girls become pregnant at a very young age. Those pregnancy outcomes were much better, both with the targeted and the non-targeted intervention. I think we're still learning. And a lot of that goes back to when I was showing you those models about the development of delinquent behavior. all of that data is based on boys. All of those good long-term longitudinal data studies that we have paid for on the federal level were done back, years ago, and girls were included in those samples solely to show you how bad the boys were, because the girls' rates of offending were so incredibly low. You come a long way, baby, that's the Virginia Slims ad. The girls have come a long way in terms of their delinquent offending, and yet there's no good data in terms of how these girls get to be delinquent, what their families look like, and what their particular needs are. And we're going to need to know that. So there's still some fundamental research that's missing here. But we know a lot about what works for these folks. And it's this looking at the multi-causal nature of these problems, including families, and including, once we know that we're doing an empirically validated service, making sure that those services are monitored and supervised. And I've moved through that incredibly fast, but that was all that I had.
Okay. Well, thank you, Doctor. We'll open it up for questions then from the committee. Representative Shields.
Thank you, Mr. Chair. What percentage of all the kids in foster care are receiving an intensive program like multidimensional treatment foster care?
In a whole different venue.
I don't know a number. I have a percentage of kids who are receiving high-end services. It's really low. The capacity is really low. And I think that one of the things that's come out of some of the work that we've done recently down in San Diego and other places demonstrates that the need is not universal. It should not be the case that every child in foster care receives a high level of services. Most kids coming into into foster care generally, for instance, kids placed with a kinship care placement are at very low rates for disruption, have nice insulating power in terms of not necessarily penetrating in terms of mental health and juvenile justice kinds of concerns. And yet we can identify very easily, and with very simple kinds of instruments and measures, which kids are at greatest risk and which kids are at greatest problem, and there's still a relatively small number of those kids who we can identify. For instance, kids who have been, I think the cutoff is right between 5 and 6 foster placement disruptions. Kids who are entering their 6th placement disruption are at over a 90% chance that any subsequent placement that we give them is going to subsequently disrupt. So those kids are the kids that we need to be focusing on, the kids that are greatest risk for long-term mental health and behavioral problems, in large part because of placement disruption.
Could I ask one follow-up?
Go ahead.
Mr. Chair. So if you could wave a magic wand and you had $10 million to spend on the foster care system, where would you put, if you just had to pick 1 or 2, maybe even 3 places you could divvy up the pie, where would you put the $10 million?
Off the cuff, because I've never dreamt that dream before. I would say that the things that I would put money into are in good, solid, validated assessment for those kids, that we could identify who those kids are who are in need of support. I think the other thing is training foster parents and ongoing support of foster parents, where it is not looked down. That getting support and activating support for behavior problems is something that is encouraged, and that we have the services there when they call. I think that the other place would be in terms of extending some kind of baseline behaviorally based parenting curriculum to the parents of kids. Most of those kids who are in placement are going back to their biological relative. The services tend to follow the kid, and if we could support those families with something that's validated and continue to do so, and I know that there's efforts on all 3 of those fronts in a number of places, but those are the things that I think seem to have the highest hit rate in terms of the long-term health and safety of those kids.
Great. Thank you.
Mr. Chair. Senator Cruz.
Yeah. Representative Shields, $10 million doesn't get you very far. Quite honestly, I guess I would be interested, based on the work we've been trying to do in the foster care system and the money we've been trying to get into it. This is a very aggressive expansion, and long term, it may be good bang for the buck. I would say that if we're going to go this direction, we're going to need an incredible amount of help to try to get the funding for